All right, hello everybody, and thank you for joining today's CMS Web Interface support call. During today's webinar, CMS will provide an overview of 2019 CMS Web Interface quality reporting from Mips groups and ACOs. And after the webinar, CMS will take as many questions as time allows. So now I'll turn it over to Fiona Larby from CMS to begin.
Thank you. Welcome everyone, and thank you for joining us today as ACOs and Mips group practices prepare for CMS Web Interface quality reporting. I'm Fiona Larby from CMS. Joining me on the call today are other CMS experts and contractors who will share helpful information on CMS Web Interface quality reporting and answer your questions during the question and answer session after today's presentation. Today's call will only focus on Web Interface quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding costs, promoting interoperability, improvement activities, Mips, or quality reporting in general. Next slide, please. This is a disclaimer slide about this presentation. Information in this presentation was current at the time it is published, but I urge you to please be sure that you're using the source documents and links that are provided throughout the presentation. And please stay tuned to any communication from the Quality Payment Program, Medicare Shared Savings Program, or Next Generation ACO model regarding any updated information. Next slide, please. The recording, slides, and transcripts for the February 12th call are now available on the Quality Payment Program library. Next slide, please. The submission period for the CMS Web Interface aligns with other submission types for 2019, opening on January the 2nd, 2020, and closing at 8 p.m. Eastern Daylight Time on March the 31st, 2020. Your submission will be automatically accepted at submission close. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website, circled here. We encourage you to submit your 2019 Mips performance period data in advance of the submission deadline on March 31st. Early submission will provide you with the time to receive assistance from the QPP Service Center, have other CMS-approved reason requests reviewed, and complete the CMS Web Interface reporting requirements. Next slide, please. As you know, today is part of a series of Web Interface support calls held weekly through the data submission period. The next support call will be held on Wednesday, March the 4th, 2020 from 1 to 2 p.m. Eastern Standard Time. Topics will include measure frequently asked questions as listed below, but will be primarily Q&A, CARE 2, MH1, and PREV 13. Additional topics may be added prior to the support call. Next slide, please. The other CMS-approved reason skip requests must be submitted through the CMS Web Interface. This is a way to skip a patient attributed to a measure during denominator confirmation. The CMS-approved reason is reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or denominator exceptions identified in the measure specifications. Patients for whom a CMS-approved reason is selected will be skipped, and another patient must be reported in their place to the measure if available. We encourage you to submit a 2019 CMS-approved reason as soon as possible and no later than Friday, March 20th. Submitting after March 20th may cause your request not to be processed prior to the close of submission. Next slide, please. This is a reminder that the 2019 CMS Web Interface API is available all year for testing in the developer preview environment. You can review the resources listed on this slide for more information. Next slide. Next, we will cover medical record documentation. Next slide, please. When submitting data through the CMS Web Interface, it is expected for CMS Web Interface reporters to retain some supporting medical record documentation demonstrating that the patient met the denominator criteria, the numerator quality action was performed, and/or any applicable denominator exclusions or exceptions existed. Due to the comprehensive and individual nature of patient medical records only available to CMS Web Interface reporters, CMS cannot provide specific feedback regarding whether or not documentation in a patient medical record, including screenshots, would meet the intent of the measure or suffice for a given measure in the event of an audit. In the event of an audit, auditors will review measure specifications in comparison to the patient's medical record documentation provided by an ACO, Mips group, or virtual group for each patient sampled for the audit. Next slide, please. Are we allowed to go outside the ACO participants to find medical record data? Yes. CMS encourages ACOs to obtain medical records for their assigned and sampled patients. This includes collaborating with physicians and/or other clinic staff both inside and outside the ACO, including but not limited to the MPIs provided in the CMS Web Interface, as well as facilities both inside and outside the ACO, with such collaboration attempts being repeated throughout the course of the data collection period, if needed. Note that the data entered into the CMS Web Interface should never reflect services provided after the end of the performance period, i.e. after December the 31st, 2019. Next slide, please. Can a Mips group add documentation to the EMR in 2020 for performance year 2019? For instance, if a colonoscopy is not found in the EMR during the data collection period for performance year 2019, and staff reach out to a performing facility to get a copy, and it is scanned in the EMR in 2020, can that be counted for performance year 2019? The QPP measures should be completed based on information that is available in the medical record prior to the end of the measurement period. There could be instances where the procedure/encounter occurred during the end of the measurement year and the medical record was updated early in 2019. But these instances should not be the norm. It would be more beneficial to the patient if coordination of care coincided with the patient's encounters as opposed to collecting missing information afterwards for purposes of quality reporting. The submission period is not intended to be a time for filling in missing information, which was only identified due to the patient being attributed to a measure for the performance purposes. The measures are not intended to interfere with clinical practices. If a measure calls for information that is not available, then the provider may not meet the intent of the measure. Next slide, please. Thank you. Now I'll pass it off to Angie Stevenson to go over frequently asked measure questions.
Hi, everyone. This is Angie with the PIMS Measures team. Our first frequently asked question today is on the MH1 depression remission at 12 months measure. The question is, in order for an antidepressant medication during the denominator identification period, is an order for an antidepressant medication during the denominator identification period sufficient to confirm a diagnosis of depression? The answer is no. There must be documentation of an active diagnosis of major depression or dysthymia during the denominator identification period, which is November 1st, 2017 to October 31st, 2018. Confirmation of the diagnosis can occur using any of the following methods. It can be a diagnosis code on the encounter or problem list, regardless of the vendor assigned description of the code. It can be the words major depression, major depressive disorder, dysthymia or dysthymic disorder, pervasive depressive disorder, on progress notes, or on problem lists. Those can be used to confirm the diagnosis as well. Additionally, in paper records, the description depression may be used with the option to confirm by billing code. Question 2 is, can you please clarify the timing used to identify the following denominator exclusions? Active diagnosis of bipolar disorder, personality disorder, schizophrenia, psychotic disorder, or pervasive developmental disorder. A denominator exclusion may be selected if the diagnosis is active any time prior to the end of the measure assessment period. Next slide, please. Okay, this question is for Prev 7, the influenza immunization measure. Does a patient refusal have to be documented during the flu season being measured, which is August 1st, 2018 through March 31st of 2019? You may document patient refusal of the flu vaccine for Prev 7 after March 31st, but the medical record documentation must note that the refusal occurred during the flu season being measured from August 2018 through March 2019 for 2019 reporting. For 2019, documentation should be during the measurement period and be specific to the flu season being reported, unless the selection is for documentation of a medical reason for not giving the influenza vaccine due to an egg allergy. A documented history of an egg allergy in the patient's medical record is acceptable for this exception for 2019 reporting. Next slide, please. These questions are for the Prev 13 statin therapy or the prevention and treatment of cardiovascular disease. Question 1 is for population 2. Is it acceptable to use any variation of the ICD-10 code E78 to confirm the diagnosis of pure or familial hypercholesterolemia? The measure requires confirmation of a diagnosis of familial or pure hypercholesterolemia. Other cholesterol-related diagnoses are not appropriate. The E78.00 and E78.01 codes are present in the PREV coding document and may be used to identify the pure or familial hypercholesterolemia. Other variations of the E78 code are not specific to those types of hypercholesterolemia. If you find other medical record documentation supporting the diagnosis of pure or familial hypercholesterolemia, then the diagnosis may be confirmed. Question 2 is, when does the denominator exception, for example, allergy or other intolerance to statin medication, need to be documented in the medical record? Medical record documentation should support the denominator exclusion as active during the measurement period. There are 2 numerator guidance notes that provide instruction regarding how to report an allergy to a statin and the timing requirement for the denominator exception. Please refer to page 14 of the posted measure specifications for that information. Thank you. I will turn it back over to Fiona Larby at CMS.
Sorry, thank you, Angie. Next slide, please. Please note that 2019 materials providing information on the Mips Quality Performance category are available on the Quality Payment Program Resource Library. We encourage reviewing these resources if you have questions on quality requirements and measures. We'll continue to communicate any future postings in upcoming support calls. Additionally, the help and support page on the QPP website contains links to materials, videos, webinars, and online courses, as well as other items to help with reporting and development. Next slide, please. The QPP webinar library also contains recordings, slides, and transcripts for past QPP webinars, including the recent 2019 CMS Web Interface user demonstration held in November, and the CMS Interface kickoff call held last December. The recording, slides, and transcripts for the January 15th, 22nd, and 29th, and February 5th and 12th calls are also available on the library. Please note that it may take 1 to 2 weeks to post presentations to the library following a webinar. Next slide, please. Finally, this slide contains links to resources available for Medicare Shared Savings Program ACOs and next generation ACO model. We encourage you to review the materials available here and sign up to each newsletter for more information. Next slide, please. If you need additional assistance, please refer to the contact information listed on this slide. Next slide. Now, just before we head into the Q&A portion of this call, if you're interested in providing feedback and collaborating with CMS on the quality payment program, we encourage you to participate in our human-centered design efforts. To get involved, please email your name, title, topic of interest, and organization to qppuserresearch@cms.hhs.gov. Now I will hand things over to Ketchen to begin the question and answer portion of this.
Great, thank you, Fiona. All right, so as we begin the question and answer period of this webinar, please remember that you can submit questions via the questions tab on your screen, or you can raise your hand and we will unmute your line. You may do so by clicking the hand icon shown on the screen. It'll turn green and we will go ahead and announce your name to unmute your line. So first we'll begin with a few questions submitted through the chat box. Your first question reads, in regards to the PREV-10 measure, can we use denominator exception for nursing home patients? My feeling is being a nursing home resident is a medical reason to not screen for tobacco use.
Hi, this is Angie with PIMS. No, just being a nursing home resident would not be a medical reason to report the denominator exception. There would need to be medical record documentation of the actual medical reason for not screening for tobacco or for not providing tobacco cessation. Thank you.
Great, thank you. All right, in regard to HTN2, if a patient has a diagnosis of essential hypertension with one NPI from a gastroenterologist from November 2018 in a more recent blood pressure reading from a different NPI of primary care, would that count, or do the diagnosis and blood pressure readings have to be from the same provider?
Hello, this is Deb from the PIMS team. First off, they do not have to be from the same provider. So the first thing you're going to do is determine if the patient has a documented diagnosis of essential hypertension within the first 6 months of the measurement period or any time prior to the measurement period, but that it doesn't end before the start of the measurement period. Once you have determined that the patient is eligible based on the diagnosis, you're going to look for the most recent blood pressure value that has been documented in the medical records to submit. And again, that doesn't matter if it comes from 2 different providers or if it happens to come from the same provider. Thank you.
Great, thank you. All right, your next question reads, for PREV-12, can you confirm that a score of 0 does not require physician interpretation to be documented?
Hi, this is Angie with PIMS. It may be assumed as negative for 2019 reporting. Wanted to remind everyone that on the January 29th CMS Web Interface support call, CMS did announce that they will accept documentation previously allowed in 2018 or documentation as outlined in the 2019 measure specifications in cases where this measure is audited for the 2019 performance year. Thank you very much.
Great, thank you. All right, so we will go to the phone line. Fatima Yusuf will unmute your line. All right, so Fatima Yusuf, you may go ahead and ask your question. Fatima Yusuf, you can go ahead and ask your question. All right, we'll move back to the questions box. Your next question asks, does the essential hypertension diagnosis have to occur in the first 6 months of 2019, or can it be found in prior year diagnoses or problems lists where it has not been marked as resolved?
This is Deb again, and I would point you back to the measure specification. The denominator is for you to determine if the patient has a diagnosis of essential hypertension within the first 6 months of the measurement period or any time prior to the measurement period, but that it does not end before the start of the measurement period. So for 2019, you would not want to confirm a patient based on diagnosis if the diagnosis of essential hypertension ended before January 1 of 2019. But as long as a diagnosis that happened in previous years, if it's still considered active in the first 6 months of 2019, does not end before the first of the year, you should confirm the patient for that measure. Thank you.
Great, thank you. All right, next we will go back to the phone line. Michael Levant will unmute your line. So Michael, you may go ahead.
Hi, thank you. So this question is in regards to MH1 and kind of piggybacking upon the slide that was reviewed earlier. So the question is really asking about the denominator exclusions. So wanted to confirm that the exclusions have to be active diagnoses. And if that's the case, what's the definition? How is active defined? Case in point would be if we found a diagnosis of bipolar, for instance, for a patient from 2016, would that suffice and meet the use of that denominator exclusion? Thanks.
Hi, this is Angie with PIMS. You would exclude the patient if the exclusion diagnosis occurred either during the denominator identification period or before the end of the patient's measure assessment period, of which the index date marks the start of that. And the intent is not to exclude a patient if the exclusion diagnosis was after the end of the measurement or measure assessment period. So, and that does vary by patient depending upon when their index event is. So I believe you asked if a 2016 diagnosis would, if that's all the documentation you had, if that would qualify the patient for the exclusion. And according to the measure specifications, no, it does have to be during the denominator identification period or measure assessment period. That is in the specifications, and I cannot come up with the page number for you right now, but I would be glad to come back to that if you need it.
And I would just, to further confirm what Angie is saying, it's not that the initial diagnosis has to happen during that period of time, but it does have to be considered active. So that patient needs to be being treated for that diagnosis for it to be a denominator exclusion.
Right, thank you, Deb.
Okay, great. Thank you both. All right, your next question concerns CM2. They are asking to please clarify the definition of active diagnosis for denominator confirmation. Is a DM diagnosis required during the measurement period or the measurement period of the year prior? As on page 7 of the measure spec, it does state to determine if the patient has a documented history or active diagnosis of diabetes during the measurement period or a year prior to the measurement period. Yet under guidance, it states that the active diagnosis is defined as a diagnosis that is either on the patient's problem list, a diagnosis code description listed on the encounter, or is documented in a progress note indicating that the patient is being treated for the disease. So can you please clarify the discrepancy there?
Yes, and I guess I would start by saying it's really not a discrepancy. The measure developer intends for you to confirm the patient has a documented history of or active diagnosis of diabetes during the measurement period or the year prior to the measurement period. So you are actually looking to confirm diagnosis for the 2019 program year. You would look at 2018 and 2019 to determine if that patient had an appropriate diagnosis of diabetes. And I say appropriate, meaning that if you look at the coding, that diagnosis is intended to be type 1 or type 2 diabetes. Thank you.
Great, thank you. All right, your next question asks, for the PREV 13 measure, if a patient is identified as denominator exception, is a patient considered performance met or not met?
And this is Deb, and I would say the patient really isn't considered either one, they're considered completed. So a denominator exclusion will remove them and replace them, but a denominator exception is a completed patient. You have submitted the information, but they will be removed from your denominator and your numerator so that they are not counting against you.
Great, thank you. All right, we will head back to the phone line for this next one. So Christina Sinkiewicz, we will unmute your line. All right, Christina, you may go ahead.
Hi, I had a question on a couple of the slides that you posted earlier today.
On the one slide, you had said that the ACO participants are allowed to go outside of the ACO to find medical record data. And then in the next one, you said that we should only be using the stuff that is already in our records from 2019 to do our reporting. So like if I see that the patient doesn't have a colonoscopy in my chart at the end of 2019, am I allowed to call the GI doctors and get the copy of that report?
Hey, this is Fiona from the Shared Savings Program. So slide 10 was related to ACOs and what ACOs can do to obtain their medical record documentation. And slide 11 was related to Mips groups and virtual groups and what they can do to maintain their documentation. So if you're an ACO, then slide 10 would be what you would follow.
Okay, so I am an ACO, so I am allowed to contact other providers outside of my organization to get information. So I could call that GI doctor to get the report.
Correct, yes.
Okay, great. Thank you.
You're welcome.
Okay, great. All right, your next question asks, for HTN2, are urgent care visits considered an outpatient visit and thus must be used if the most recent visit is in 2019?
This is Deb from the PIMS team, and just to kind of point you to coding, if you are coding urgent care visits, typically coded as 99201 through 99215, those codes are included in the coding document for the hypertension measure that is posted on the QPP resource library. So yes, you would want to include blood pressure values from those visits. Thank you.
Great, thank you. All right, next question concerns PRES 12. Does the documented condition intellectual disability qualify as a denominator exception? What about dementia or Alzheimer's?
Hi, this is Katie from the PIMS team. So for the denominator exceptions, there aren't specific diagnoses tied to that particular exception. In order to claim an exception, you would need to have documentation that a screening was not performed due to the patient's diagnosis or condition. So your documentation would need to support the reason why they were not screened in order to use the denominator exception. But again, just to reiterate, there are no specific diagnosis tied to the use of that exception. Thank you.
Great, thank you. All right, just as a general reminder, if you would like to submit your question over the phone and speak directly, just go ahead and click the hand icon next to your name and we will unmute your line. In the meantime, going back to the questions box, for CARE 2 fall risk screening, if a provider documents no gait problem in their assessment without specifying no falls, or that a specific screening for gait was performed, does that meet the measure?
So this is Deb. I can't speak, I'm going to be unable to speak specifically to medical record documentation, but I can tell you if you look at page 5 at the definition of screening for future fall risk, if you have assessment of whether an individual has experienced a fall or problems with gait or balance, that does meet the screening definition. So you would just want to ensure that your documentation is in fact meeting the way the measure has defined or provided guidance, and that would be acceptable. Thank you.
Great, thank you. All right, your next question asks about statin therapy for the prevention and treatment of cardiovascular disease. It is their understanding, they'd like to check that their understanding is correct, that there are 3 population groups with unique patients in each, no double counting. And each of the 3 numerators and denominators are combined for the creation of one rate to be both submitted and scored. Is that correct?
Yes, I think so. And I want to make sure that what you're saying and how this measure is specified are the same. So just for Prev 13, we've seen several of these questions start to come into the service now. And so that you are aware, there are 3 distinct populations. However, the intent is that you are walking through each of those populations in the order that they are specified. So you are going to go through first and determine if the patient meets the patient population for criteria 1. If the patient does not, you'll move into criteria 2. If the patient meets criteria 2, you will not go into criteria 3. At that point in time, you will be answering whether or not the patient meets the numerator quality action. So are they on statin therapy? Same goes with if you go all the way through to patient population number 3 and you answer there, you're at that point answering the numerator. So it is, the quality action is statin therapy. The measure just happens to be specified in a way where there are 3 different populations, but the measure developer intends for you to walk through those 3 populations in order that they are identified in the spec. Thank you.
Okay, great. Thank you for that. All right, your next question asks for clarification on slide 11. As it was stated that we shouldn't be getting documentation for measures after the performance year is over. But again, they are confused between slide 10 seeming to negate that. So please, can you clarify? And I will go ahead and bring up those slides now. All right, so slide 10 is up on the screen. So if you could just clarify the difference between slide 11, as it was stated that we shouldn't be getting documentation for measures after the performance year is over, and what slide 10 is saying. Thank you.
This is Fiona from the Shared Savings Program. So slide 10 is related to ACOs, who are in the Shared Savings Program and the next generation ACO model. Slide 11 is related to Mips groups and Mips virtual groups. That's why they both say that's why they're different. So if you belong to an ACO or next generation ACO, then slide 10 applies to you. If you're a Mips group, then slide 11 applies to you. Thank you.
Great, thank you for that. All right, so your next question concerns Prev 7. If the patient reports month and year for the immunization, does that meet the requirements, assuming that this is documented in the EMR?
I'm sorry, this is Deb. Can you repeat that? I wasn't tracking to that particular question.
Yes, of course. It asks for Prev 7, if the patient reports month and year for the immunization, does that meet the requirements, assuming that this is documented in the EMR?
Yes, for Prev 7, basically what you need to have is you need to have medical record documentation that confirms that the patient either received, denied, has a medical reason for not receiving the flu vaccine during the flu season that's being measured. So as long as your medical record documentation is confirmation that they received the vaccine during the appropriate time period, it would be acceptable.
Great, thank you for that. All right, your next question asks, if a patient has CKD stage 5 but is on a statin, would you enter an exception or submit as yes?
So this is Deb again, and this kind of will be an answer that you can kind of take the logic of it to all of the different measures that have denominator exceptions, unless there is something very specific in the measure that states otherwise. Denominator exceptions are such that it is possible the patient is meeting the numerator. So in the case of Prep 13, if the patient is on statin therapy and there is a denominator exception, you can select that they are on that statin therapy, and then that is a performance met. That is different than the denominator exclusions. Denominator exclusions are conditions that the measure developer did not intend for those patients to be included in the measure itself in meeting the numerator compliance. And so those patients, if you look at the flow within each of the specifications, you would skip them as a denominator exclusion and they would be replaced. Thank you.
Great, thank you. All right, your next question asks, for MH, what is the measure assessment period for the exclusion? Can you please clarify that?
Hi, this is Katie from the PIMS team. So for using the exclusions within MH1, that time frame would be marked by the index event. So that's the date that would which the first instance of an elevated PHQ-9 or PHQ-9M and the diagnosis of depression or dysthymia. So that period is flagged within the measure as November 1st, 2017 to October 31st, 2018. That begins your measure assessment period, which is the 12 months plus or minus 60 days in length that allow for that follow-up PHQ-9 or PHQ-9M. So any time between the index event date and the measure assessment period could be utilized to determine those denominator exclusions. And that would look a little different for each patient based on when that index date initiated. Thank you.
Great, thank you for that. All right, just a reminder, we do still have the phone line open, so go ahead and just raise your hand if you'd like to ask a question over the line. All right, in the meantime, for MH1, is the PHQ-9 score enough, or do all questions need to be answered and documented in the medical record?
Hi, this is Katie again. So all 9 questions do need to be answered in order to have a valid summary score according to page 12 of the measure specification. So the way in which that's documented in your medical record is really up to your organization, but it must support that you do have that valid summary score and that you're able to truly determine what their initial PHQ-9 was. Thank you.
Great, thank you for that. All right, so for Prep 13, does it have to be a diagnosis of familial or pure hypocholesterolemia, or can hyperlipidemia be a qualifying diagnosis?
This is Deb. I'd point you to 2 sections. The first is in the posted Prep 13 specification on page 6. Patient population 2 does include the currently having an active diagnosis of familial or pure hypocholesterolemia. The other place you may want to confirm what diagnoses are appropriate if you're trying to determine if patient population 2, if your patient is qualified for that particular grouping, is to look at the posted coding document for the diagnosis codes that would be associated. Thank you.
Great, thank you. All right, and we would just like to clarify an earlier response. There's a question asking if there is medical record documentation in 2019 that a colon cancer screening was completed, but they don't request the record until 2020, is that allowed?
Hi, this is Katie from the PIMS team. So we would point back again to those slides, excuse me, I believe 10 and 11. So the way you gather your medical record data within the data collection period would really be dependent on whether you're a Mips group or an ACO. So again, if you are a Mips group, we would refer you to the reference on slide 10, and then for ACOs, we would refer you to the reference on slide 11. Thank you.
Great, thank you. And for that clarification, we do have slide 11 up on the screen. All right, next question concerns MH1. They are finding that a majority of their patients are being skipped due to a lack of initial PHQ-9 or values that just don't meet the standard. Do they exhaust their entire patient sample in that list? And can you confirm whether there's any other action they should take?
Is there someone from Semantic Bits that would be able to respond to this question?
Hi, this is Awesome. I can respond from the application perspective. If you skip a beneficiary in MH1 that is ranked in the minimum reporting requirement, which is 248, you will need to complete the next beneficiary in the sample. If you find yourself skipping all the beneficiaries, almost all the beneficiaries, you need to complete 100% of the beneficiaries you have in your sample in order to meet the reporting requirements for MH1. Thank you.
Great, thank you. All right, your next question concerns PREV 13. Is a lab result with a diagnosis enough to satisfy the measure, or does a doctor or clinician have to make mention of it in the medical record?
So this is Deb. I didn't want to just kind of avoid your question. I do believe this is one that was answered through ServiceNow, but if not, what I would recommend, if I'm understanding your question right, is really to look at the posted specification starting on page 6. The denominator is, you're going to look through step by step to determine if the patient meets any of the criteria. So the first criteria you're looking for is their age being greater than or equal to 21 with a clinical ASCVD diagnosis. If the answer is yes, then you're going to go ahead and submit whether or not they're numerator compliant. If the answer is no, you'll move on to the second population, which is to see if you can determine if the patient has ever had a fasting or direct lab result LDL-C of greater than or equal to 190. Or were previously diagnosed with or currently have an active diagnosis of familial or pure hypocholesterolemia. And if the answer is yes, in this case, you move on to determine if they are on statin therapy. And then the third patient population, if you say no to number 2, is if the patient is aged 40 to 75 years of age at the beginning of the measurement period, with type 1 or type 2 diabetes with an LDL-C result of 70/189, recorded as the highest fasting or direct lab result in the measurement year or during the 2 years prior to the beginning of the measurement period. And then, of course, you've got your denominator exclusions and exceptions that are included in the specification. I know one of the things that I find to be the most helpful is to look at the measure flow first and see how things are going to be pulled out. As I'm trying to find, verification if the patient belongs in the denominator. So I'm not real sure exactly what you're saying is if the only thing you have is a lab, if that lab result, the patient is a particular age, that lab result is a fasting or direct lab result, LDL-C of greater than or equal to 190, then that would pull the patient into patient population number 2 as long as you have that medical record documentation. I hope that answered your question. If it didn't, please open up a ServiceNow help desk inquiry and we will make sure to get you a response. Thank you.
Great, thank you for that. All right, so we'll pass it back to Fiona to just quickly read through slides 10 and 11 and the differences between these. So we'll start with slide 10, and Fiona, it's all yours.
Thank you. So the question is, are we allowed to go outside the ACO participants to find medical record data? The answer is yes. CMS encourages ACOs to obtain medical records for their assigned and sampled patients. This includes collaborating with physicians and or other clinic staff both inside and outside the ACO, including but not limited to the NPIs provided in the CMS Web Interface, as well as facilities both inside and outside the ACO, with such collaboration attempts being repeated throughout the course of the data collection period if needed. Please note that the data entered into the CMS Web Interface should never reflect services provided after the end of the performance year, i.e. after the 31st of December 2019. This slide refers or should be followed by ACOs in the Shared Savings Program and ACOs that are part of the Next-Gen ACO model. Slide 11. The question here is, can a Mips group add documentation to the EMR in 2020 for performance year 2019? For instance, if a colonoscopy is not found in the EMR during the data collection period for performance year 2019, and staff reach out to a performing facility to get a copy and it is scanned in the EMR in 2020, can that be counted for performance year 2019? The answer is, the QPP measures should be completed based on information that is available in the medical record prior to the end of the measurement period. Instances where the procedure encounter occurred towards the end of the measurement year and the medical record was updated in early 2020, but these instances should not be the norm. It would be more beneficial to the patient if coordination of care coincided with the patient's encounters as opposed to collecting missing information afterwards for purposes of quality reporting. The submission period is not intended to be a time for filling in missing information, which was only identified due to the patient being attributed to a measure for performance purposes. The measures are not intended to interfere with clinical practices. If a measure calls for information that is not available, then the provider may not meet the intent of the measure. Thanks, Lauren.
Great, thank you. Thank you for that clarification. All right, on a similar note, we did have a question come in asking whether CMS provides documentation that others can provide to people outside of ACO providers to be able to obtain medical records for ACO attributed beneficiaries.
I'm actually not sure I understand the question. Sorry, Lauren. This is Fiona again.
No worries. I'll try reading it one more time. It asks, does CMS provide any documentation to provide to outside the ACO providers in order to be able to obtain medical records for ACO attributed beneficiaries?
This is Fiona again. CMS doesn't provide any documentation. It's up to the ACO to coordinate care amongst their providers and suppliers and any providers outside of their organization.
Great, thank you. All right, just a reminder, if you would like to ask your question over the phone line, please go ahead and raise your hand and we can unmute your line. We'll wait just a few minutes for 2 more questions. Okay, we have a question on MH1. They're asking an MH1 follow-up PHQ-9 shows remission is out of the time range by 1 to 2 months. Should they submit an exception ticket or accept the skip? as the majority of the 616 sample has been reviewed.
Hi, this is Katie from the PIMS team. So for MH1, the remission would need to occur within that 12 months plus or minus 60 days. So if your patient's follow-up PHQ-9 is outside of that window, we would consider that performance not met because it does truly need to occur within the time frame specified by the measure. Thank you.
Great, thank you. All right, we do have a few questions now over the phone line. So Margaret Alcala will go ahead and unmute your line. All right, Margaret Alcala, you may go ahead.
Hi, this is a clarification for PREV-12. In the absence of a screening tool like PHQ-2 or PHQ-9 or any of the depression screening tools in PREV-12, will a section in the review of systems stating that the patient has no depression, no anxiety, and no suicidal thoughts suffice to meet PREV-12?
So this is Katie from the PIMS team. So this would be another instance where we wouldn't be able to speak specifically to, how an organization is documented within your medical record. It would truly be up to your organization to determine whether your documentation supports that a screening was done, contain that provider's interpretation, and then, if positive, have the documented follow-up.
Right. Okay, thank you.
Great, thank you. All right, your next question is also from the phone line. So it's Christopher S. Swan. We'll go ahead and unmute your line. All right, Christopher S. Swan, you may go ahead.
Hi, I have a question for MH1. If the patient's depression is documented as being in remission, does that still count as the diagnosis being active during the measurement period? How should that first question in that MH1 measure be answered?
So this is Katie from the PIMS team. So the initial population does apply to patients who are 18 years of older, or the denominator confirmation would utilize that active diagnosis of major depression or dysthymia associated with the elevated PHQ-9. So this might be a case where we would actually encourage you to submit your question to qpp@cms.hhs.gov just so we can take a little bit closer look at it, because it may depend on when that remission occurred, if it was after that index date or prior to. So we might need to take a little bit of a closer look at your question here.
Okay, thank you.
Great, thank you. All right, your next question asks, in regards to the PREV-13 previous question, if the only diagnosis for the entire measure is a lab result diagnosing atherosclerotic disease and nothing else that supports the other populations, is that lab diagnosis enough to meet the measure?
So this is Deb. Within the denominator of PREV-13, I'm assuming by your question, you've said no to the patient being age 21 years and older with a clinical ASCVD diagnosis, but the patient is 21 years of age or older and has had a fasting or direct lab result, LDL-C greater than or equal to 190. If that is yes, the patient does qualify for the denominator of the PREV-13 measure, and you should move on into the numerator and answer the questions there. Thank you.
Great, thank you. All right, so we have time for just one or two more questions. We will take one more from the phone line from Raina Kaplan. So Raina, we've gone ahead and unmuted your line.
Hi, thank you. Just to clarify again, I know we've been talking about this a bunch on the medical record documentation component for ACOs, that I want to make sure that it is true, as it says here, that it is okay to collect data from outside providers during the measurement period. So for example, if we use claims to identify providers, like the example earlier in this, let's say a GI physician through a claim, and then go after that report during the measurement period for a service that was provided in performance year 2019, that's still acceptable.
Hi, this is Fiona from the Shared Savings Program. Yes, that's still acceptable. If the procedure was performed, if you're looking for a procedure from a GI, if it was performed in 2019, and that's the measurement period, then it is acceptable to go outside of the ACO to find that information.
Okay, thank you. This seems to be a clarification from last year. I feel like originally this was the guidance that we were given, and years prior, last year, the guidance seemed to have been similar to slide 11 for the Mips groups, and so we had been working under that guidance, but it is good to know that we can still do this collaboration during the reporting period. Thank you.
Great, thank you. All right, so we have time for one last question from Shelley Simpson. Shelley, we've unmuted your line, and you may go ahead.
Okay, hi. This is in reference to Prov 12 and a question that was just asked for depression screening. The question that was asked specifically said, if our physician notes that the patient denies depression, no depression in its notes, does it work? And you guys kind of referred to it saying it's really dependent on what your organization considers depression screening and if that passes. But in the measure specifications, it clearly says that it has to be a named tool. And the reason I ask is because we do have cases that have fallen out that the physician's documented everywhere. Patient denies depression, but I don't have the PHQ-2 in there, and so I counted it as a fallout. So it's important to me because if what you answered if my organization and that physician considers that a depression screening and we don't have to utilize the tool, then that would be a passed measure instead of a failed measure.
Hi, so this is Katie from the PIMS team. I think the question earlier might have been a little bit different in terms of when I think the question was that the patient, or excuse me, I think the other question may have been MH1 and documenting depression and remission.
Yeah, this was just asked like 2 questions ago, just like 2 or 3 questions ago.
Sure. So, I mean, I will say for the intent of the measure, it does require a standardized depression screening tool. And your medical record documentation must support that normalized validated depression screening tool was utilized for that initial depression screen. So does that help clarify? Or, I mean, we can also talk through this further if you would like to submit a question.
No, thank you. That's what I thought. No,
okay.
That's what I thought. I was just verifying that so that I wouldn't be incorrect in our assessment. Thank you.
Yep, you're right. Okay, thank you.
All right, great. Well, that takes us to 2 o'clock. So Fiona, we will pass it back to you to conclude the webinar.
Fiona, will you conclude the call? Yes, I'm on mute, sorry. Thank you for joining us today. The slide deck, recording, and transcript from today's call will be available on the QPP webinar in the next 2 weeks. As a reminder, our next support call is scheduled for next Wednesday, March the 4th from 1 to 2 p.m. Eastern Time, during which we will cover assignment and sampling, frequently asked questions, as well as frequently asked questions related to Care 2, MH1, and Pref 13. We hope you'll all join us. Thank you.